Good afternoon, everyone. Good afternoon and welcome. I'm Sonia Irby. I'm president of the National Coalition of 100 Black Women Incorporated, Dallas Metropolitan Chapter. I want to take this opportunity to welcome you to this healthcare legislation and the impact on our communities session, part 2. But before I turn over to our co-chair today to introduce our esteemed panelists, I want to take a few moments to just tell you a little bit about our organization. The National Coalition of 100 Black Women Incorporated is a 39-year-old advocacy organization founded in 1981 with 61 chapters and over 3,500 members across the United States. Our mission is to advocate on behalf of Black women and girls to promote gender equity and leadership development in the areas of health, education, and economic empowerment. Our vision is to see Black women and girls live in a world where socioeconomic inequity simply does not exist. The Dallas Metropolitan Chapter was chartered in June of 2018, so we're coming up on our 3-year anniversary. And our vision was to be a voice in the community and address the concerns of Black women and girls in the Dallas area. So we've been working really hard over the past 2.5 years to make that vision come to life. And I am honored to serve as the president of our organization. One of the ways that we advocate is through programming like the one that you're attending with us today. We cannot do this without the support of great partners. On a national level, our organization has partnered with some key strategic partners, the Coca-Cola Company, the Truist Foundation, Major League Soccer, and Walgreens. All of these great partners have come together with us to help us advance our mission and our vision. We also issue position statements or take a position about the rights of those in our community. And very recently, you might have seen a letter that we sent to the Texas Governor, Greg Abbott, regarding our concerns around Senate Bill 7 and the impact to Texas voters. This letter was jointly signed by all presidents of our 3 chapters here in the Texas area, our Dallas chapter, our Houston chapter, and our San Antonio chapter. So if this is your first time joining us, we do hope it will not be your last. We want to invite you to stay connected with us. We hope that you'll come back for our next Sisternomics, which is our financial literacy series on wealth building on May 20th. And also the last installment of our Barbara Jordan Civic Engagement Series, Women in the Texas Judiciary, will be held at noon on May 26th. So we appreciate you joining us today and spending your lunch hour with us. If you're watching via Facebook, we ask that you tag this broadcast, share it with your friends, and ask them to join us as well. And next, I want to just share a little bit about why Barbara Jordan Civic Engagement. As you all may know, Barbara Jordan was an American lawyer and a politician who was a leader in the civil rights movement. She was a Democrat. She was the first African-American elected to the Texas State Senate after Reconstruction and the first Southern African-American woman elected to the United States House of Representatives. So we thought that it was only fitting that this series bear her name. And so with that, I'm going to turn it over to our co-chair, Tanzania Vincent, who will introduce our illustrious panelists today. We will take Q&A after the session, and so please do put your questions in the chat, and we will do our best to get to as many of your questions as possible. So thank you again for joining us, and Chair Vincent, I'll turn it over to you.
Thank you so much, Madam President Irby, and welcome everyone. I'm really excited. You know, this is our second installment this year of the Barbara Jordan Civic Engagement webinar series. After the first one, we had an after set, if you will, with the panelists, and our conversations continue to talk, and we thought it would only be fitting to do part 2. And so we're going to welcome back 2 of our panelists, and then we have a new panelist joining us today. And so for the next slide, I'll begin with the introductions, and really looking forward to an absolutely wonderful conversation today. So our first panelist is Dr. Richard Broussard. He is the co-founder of Reach Out, Rise Up, a 501c3 nonprofit organization focused on implementing strategies that alleviate health disparities caused by poverty as evidenced by socioeconomic inequities affecting all of the environment in which we live. Now, Dr. Broussard is a graduate of Christian Brothers University, and he also earned a Doctor of Pharmacy from the University of Tennessee Health Science Center, located in Memphis. He's actually one of my, he's a fellow alumni as well. So very excited to have him here. He currently serves as the National Medical Director of Reverend Peter Johnson Institute for Nonviolence, and he's also a certified mental health crisis intervention specialist. Welcome, Dr. Broussard. And I think you also mentioned you wanted to mention your current employer. You can just take a moment to mention where you're currently working for the panel.
Yes. Can you all hear me?
Yes, we can hear you.
Okay. Yeah, currently I'm working on COVID community stabilization with MCI, which is a service disabled operated small business. It's a Black-owned business. It's Colleen Payne. They relocated from Oklahoma City, from Tulsa to Dallas. And so we're working, we're doing vaccinations pretty much. That's where I am now, really trying to affect change in a positive way. Dealing with, as we see the health disparities that have been peeled back by COVID. So we're just continuing to do the work that's required to reach health equity the best we can.
Excellent. Thanks so much. We're looking forward to you sharing your perspectives. And so if we go to the next slide, I'll introduce our second speaker. It's Dr. April Allen. She's also a fellow alumni of University of Tennessee. She is the anticoagulation clinical program manager at the VA North Texas healthcare system and is a clinical pharmacy specialist in anticoagulation. She received her Doctor of Pharmacy degree from the University of Tennessee in 2002, completed a pharmacy practice residency in ambulatory care residency at the Regional Medical Center in Memphis, Tennessee in 2003. She also received the Roche Pharmacy Communication Award in 2002 and received her certification in anticoagulation recognition in 2010. She was also an assistant professor with Texas Tech University Health Science Center School of Pharmacy from 2004 to 2011 in the primary care division. Dr. Allen serves as an adjunct faculty to Texas Tech precepting resident. So again, welcome back, Dr. Allen. Good to have you here. Excellent. And then our next panelist, last but certainly not least, Mr. Kebron Alexander, currently serves as the second vice president of Dallas NAACP and the healthcare chairperson to the Dallas chapter NAACP for the last 5 years. Prior to that, he served as healthcare chairperson for Dallas Area Interfaith. And during this time in both of these organizations, he's been a regular vocal advocate for Obamacare enrollment and CHIP enrollment. He also works with Every Texan, a Texas policy group advocating for Texas Medicaid expansion, and Cover Texas Now network. He's also worked in the greater Dallas community of churches and the group Hands Together for Peace to successfully have ordinance passed by Dallas City Council preventing gun shows in the Kay Bailey Hutchison Convention Center and sponsoring fundraiser for Paul Quinn College in the Meyerson Symphony Hall. He has a very active interest in the community, healthcare, and education, and is a former candidate for city council. So welcome back, Mr. Alexander. Great to have you today.
Thank you for having me.
Awesome. So let's get right into the discussion. So as we mentioned before, this is our healthcare legislation and the impact on our communities, part 2. And the purpose of this session is to create awareness around the new policies and healthcare legislation in Texas. And so we know that the 87th legislative session is ongoing right now. And so a lot of things are happening now. So we're going to focus a little bit on that. And again, we wouldn't be able to get to everything that's been covered in this legislative session, but we really want to focus on the healthcare aspects and the impact on our communities. So I'm going to start off by talking a little bit about the social determinants of health. And these are conditions that in our environments where people are born, live, work, and play. And we talk about a wide range of health functioning and quality life outcomes and risks. So some of these examples are safe housing, transportation in neighborhoods, racism, discrimination, violence, education, job opportunities, and income, and then access to nutritious foods, et cetera, pollution, language and literacy skills. I'm going to start with Dr. Broussard because he mentioned to me as we were preparing for this webinar that he has a particular interest in this from a study perspective. And so if you could just highlight maybe some of the work that you're focusing on and maybe emphasize one of these and how they impact our communities.
Thank you. Well, I always like to take historical context to see as what worked in the past, as to what we can do now to close the gap or bend the curve on health disparities. So dating back to 1899 with W.E.B. Du Bois, Harvard graduate, a PhD, did the Philadelphia Negro when he moved into the 7th Ward, him and his wife, dealing with, the health disparities amongst people in that area. And what his studies, he was the first social scientist to do work in that area as far as to health outcomes and how the environment plays a role into that. From at that time, it was believed that, Blacks were not even human. So our disadvantages economically was looked at as, they just can't pull themselves up. They just can't get to where they need to be because of who they are as a people, not the social determinants, the environment that we were living in. You fast forward to 1966 when Dr. King talked about these same things at the Medical Committee for Human Rights. So that's what we're really talking about, where he says all the forms of inequality and justice in healthcare is the most shocking and inhuman. It was misquoted as inhumane. As we know, inhuman is, a lot worse than inhumane. The fact that we continue to fight and strive for the value of our lives, and how this plays out from structural determinants such as education, maternal health, gaps in healthcare, and what we've been doing. The first initiative we took was during COVID. We saw the kids were not, food insecurity was a big thing. The kids were not getting food. And we know that from an early childhood development and cognitive standpoint, that these early childhood experiences cause stress, toxic stress. So you have positive stress, tolerable stress, and then you have what, is quoted as toxic stress, and how these experiences pertaining to our environment get into the brain architecture, and it lays down these foundations that we have neuroplasticity. But at the same time, once those foundations are laid, in particular from prenatal to 8, so better is always earlier than late. It costs us more to do the work on the back end. So from prenatal to 8 is the best intervention. So you start to look at mental health and nutrition, cognitive development, and the things of that nature as far as our health outcomes. And you see that our children are already disadvantaged, and these things not just psychological, but physiological health outcomes, from atherosclerosis to increased inflammation, diabetes, hypertension, all these things that we saw with COVID that are putting us at increased risk for morbidity and mortality. So we started doing gardenings with partnering with the churches. We did one at Freedom Missionary Baptist. So we're trying to get funding to create a sustainable food source and also develop some economic opportunities such as urban gardening, farmer markets, and really start to take control of what we can control, as we know that policy it really dictates on a reach rate level that things have to change, but there are some things that we can do. So we're looking to work with anybody that's willing to do the work to try to bend the curve on these health disparities.
Thanks so much for sharing your perspective. Dr. Allen, any thoughts on any of these social determinants of health from your perspective?
Yes. As a healthcare provider, I'm going to take it from that angle because we kind of started this conversation last time about talking about how healthcare providers need to become more woke about these things, because we're always around them all the time and may not even recognize that and realize that from a healthcare provider standpoint. And I want to applaud Richard for the work that he's doing, because it sounds like he's hit on some things that are very important in the work that he's doing. And so from the angle that I'm going to look at it is more from the healthcare provider standpoint, and looking at from that side of the house, and also some of the work that I've started doing in this area is just trying to make people become more aware of what our role is in not to create healthcare disparities, and COVID helped to address that issue and wake us up to that even more. And currently I'm starting to work with the National Anti-Coagulation Forum as a co-chair for a committee called the Inclusion, Diversity, Equity, and Allyship Committee. So where we're trying to make sure we are increasing diversity within our organizations and other organizations, and by reaching out and networking with different organizations that I've had a chance to work with, I'm seeing in the C-suite that there needs to be more people of color in those areas and more diversity. So that's one thing that I'm passionate more about promoting, because I think if we get more people to be more open to have conversations considering things like racism and healthcare disparities, I think that we can kind of tackle this from a different perspective. So that's a little bit of the work and background I've started to do in this area more. And this is just a healthcare provider is working with students and residents and just telling people, hey, be more alert to these things, because when a patient leaves the hospital, we still have a responsibility to that patient.
Right.
Over from the time that they leave. And I was recently exposed to a situation that happened in the Dallas hospital, not within my system, but another system, where a patient left and the doctor just didn't care after they left what happened. But that's where it all begins in the community.
Absolutely.
And one of the things that's very near and dear to me will be access to nutritious foods and physical activity opportunities. That is one area that I do believe that we really need to have a big impact on, because without getting good nutrition, getting good food, not being able to have those resources, it does lead to bad outcomes and chronic diseases, things like eating fried foods for hypertension, having foods high in sugar for diabetes, having foods high in fat for hyperlipidemia, and on and on and on. Then you also have deficiencies in vitamins that we're not getting, especially as African Americans. We are not taking enough vitamins and minerals in our diet, and that's something that's lacking. And then physical activity is a whole nother aspect, because we live in a world now where the TV, the iPhone, the iPad is what everybody wants to do, the video games. No one wants to go outside and play anymore. So we really need to increase our physical opportunities. So those are some of the things that I've observed when it's come down to a disparity, is that we need to have our children especially starting to eat right at an earlier age and starting to have more physical activity. But we also need to be able to provide those nutritious meals for those children at an early age too.
Thank you so much, Dr. Allen, for that healthcare perspective. Mr. Alexander, any thoughts on these social determinants of health from your work and your interests?
I have a couple of ideas as it specifically relates to planning and the legacy of planning, or low esteem planning, as various governments have planned for an expansive and robust economy in certain areas of town, and left everybody south of Interstate 30 in Dallas to kind of fend for themselves with what was happening with integration at the time. That was the 1970s, early 80s, and where has the infusion of capital been since 1980? South of 30. Cedar Hill has taken off. Lancaster has seen a bit of a boom, but when we're talking about the city of Dallas, there hasn't really been that infusion of capital. There's been a removal of medical facilities. There's been a removal of high quality grocery stores and other indicators of prosperity, of health and wealth in the community. And what has taken over is an overabundance of fast food facilities. There are no public health encouraging activities. And when you close the Moreland Y on Ledbetter and just say, hey, we out, and there's nothing really there to replace it, nobody's really encouraging bike riding or bike trails or other types of physical activity, because the city of Dallas is incidentally planned to concentrate poverty in the Black parts of town, in the parts of town that they've deemed to be less desirable because developers said so. The developers can't figure out how to make uptown money happen in Wynwood, in Lancaster Keast, and in other parts of Dallas, Pleasant Grove also. Let me not exclude them. And we are left with the residue of that indifference. That indifference is costing us lives. That indifference is adding to the violence in our community. It's adding to the mental health burden that our community has to suffer and accommodate time and time again. Those types of legacy issues then come into play because the indifference of suburban legislators, they aren't concerned with what's happening here or there, where you can get the biggest bang for the buck by making a policy that is specific towards an urban area. They're looking to limit the proliferation of positive policy that has the largest benefit for all. And as long as it doesn't cost them votes in their already narrowly defined district, they don't feel that there's any need to adjust. And that's where we are. We've got certain persons in government that are willing to open up the state so they can throw out the first pitch for the Rangers baseball game until Major League Baseball takes a DEI position and says, y'all are trying to kill some voting rights for your own residents. Yeah, we're not too good with that in Georgia, but Texas is making noise because we're trying to do the exact same thing in terms of restricting votes. Mm-hmm. That all plays into our mental health. That all plays into our collective well-being. And that's collectively something we have to address from our comfortable seats as well as our uncomfortable seats at work.
Thank you so much. And so hopefully everyone can kind of see the different perspectives of these panelists and really how there is true an overlay of poverty, of healthcare legislation and legislation in general, policies that can impact all of these social determinants of health. And so with that in mind, I had mentioned before that the Texas 87th session is ongoing right now, and there's been a lot of activity. And so I just want to talk about a few of the bills that specifically relate to healthcare policy and the impact on our communities. There are so many others. I would encourage everyone to really take a close look, because I think sometimes we might take a step back and ask, why are these things happening? But if you look closely, you'll see that there are policies that can directly impact our communities. And so with that, and we'll do this in a panel discussion, and keeping in mind of the time, because I know it's at the noon hour, people are having lunch, and I know most of us have a hard stop at 1, but let's get into this. So we talked a little bit about COVID-19. We know that it has had a huge impact on the entire world, but House Bill 2902 would establish a COVID-19 task force to study factors contributing to the disproportionate COVID-19 outcomes. We know that it has a disproportionate health impact and impact in poverty in our communities in particular. And so just wanted to, very quickly, because I want all three of you to weigh in on this, maybe a minute or two each response. What impact to the economics in the African American community, particularly women and girls, have you seen as a result of the COVID-19 pandemic and quarantine? Dr. Allen, I'll start with you.
Sure. I think the biggest impact that I've noticed and seen has been more in the service industry or the gig industry, because you do have a lot of women that are either hairstylists. They are also working in restaurants. They're also maybe even doing Uber or Lyft type things. But then when those things kind of shut down, and one of the things that was very noticeable was about when school shut down, was about childcare issues, having to stay home with their child. So women were having to choose between trying to go out and work and trying to take care of their child and make sure that their child was able to get their schoolwork done. So that has been one of the biggest impact and economic impacts that I have noticed, and I still see this to this day, that where you having women trying to determine, do I work, do I stay home? And so that would be the biggest thing that I have seen, just to keep it short.
Thanks so much. Mr. Alexander, your thoughts on this COVID-19 task force to study these disproportionate impacts to our communities? Any thoughts?
The whole notion of a study is a great appeaser for persons who really don't want to do a whole lot. We know that they're going to require some type of study or task force. The fact of the matter is, we know that hourly workers, hospitality, restaurant, hotel workers were the most severely impacted and had the most to lose by the shutdown. But they are in industries where their bosses, the guys higher up, make money hand over fist. That's why they wanted a return to business as normal, so that everybody could resume their normal activities. That's why we're looking at stadiums opening up at 100% with no mask requirements, schools opening up with no testing or vaccination requirements as of yet. And women, over 50% of the population, are the most sacrificed persons in our society, because they have to take care of mom, other older relatives, and kids. And if there's a spouse or partner, women are literally in a position where they have to do everything for everybody. And the first person that gets sick, mama or our daughter, is the person that usually has to pick up that burden. And that means that their budget is also affected. Their household budget is affected and strained that much more. It's really sad that it's always got to be a study. There needs to be a pandemic special session that can really deal with it, but nobody wants to make that call. So I'll just leave that out there as something to think about.
Dr. Broussard, any thoughts on this particular House bill?
Well, they covered it so well.
Okay. We can actually move to the next one, and maybe you can, if we go to the next slide, because this actually piggybacks on this particular topic, and I'll let you weigh in on this, Dr. Broussard. So House Bill 4139 would reestablish the Health Equity Office to promote equitable health outcomes from minority communities. And this is done in the wake of what we've seen for COVID. And so what do you think the impact of this type of office will be? And then keeping in mind that other question.
Well, I'll kind of piggyback off what Kebron said. And, all these things sound good on paper, right? But first thing I noticed when I saw it was like reestablished. So there was an office at one time, but to have an office and to create sustainable change, those are, mutually exclusive sometimes. So if we really want to start to take action, that's what we need. We need action, doing studies, the American Medical Association has come out and said being Black in America is a public health threat. This has been documented as of August of last year, that just living as a Black person in America puts you at increased risk for morbidity and mortality, just everyday life, on from your work environment. And actually, Robert, I think his name is Spolinski, he's a guy that's been doing this type of work for 30 years for Stanford. And he showed that even on animal and human scales that, the type of job that we have. So where you are on the hierarchy of jobs, as for a CEO down to the worker that makes minimum wage, there are studies that show that the increased stress leads to atherosclerosis, which puts you at increased risk for heart disease, just being, on the low end of the totem pole. There's plenty of documented studies out there, data statistics out there. But the thing is, if we want to reestablish this health equity office, what is the plan of action? And, we have to realize that all these things we're talking about, food insecurity, safe and affordable housing, the gaps in care for maternal mothers, and the health outcomes for the children, starting especially with the most disadvantaged communities. Maternal health, even before the woman becomes pregnant, is paramount.
Yes.
And we have to really look at this thing comprehensively. It's going to take a multidisciplinary approach, from sociologists to geneticists, and we really have to come together and form a true collaboration and get our egos out the way so we can get some work done.
That is great. And, speaking of a multidisciplinary approach, this next House bill certainly kind of gets to this. So switching from COVID, let's talk about mental health. We know the tremendous impact that COVID has had on the mental health and well-being of everyone. But this particular House Bill 1050 is going to study employing mental health professionals or mental response teams when responding to behavioral health related emergency calls. And we know we've seen this crises happening over and over again in terms of individuals who might be having a schizophrenic break or et cetera, and they're either arrested inappropriately rather than getting to a mental health facility, and unfortunately detrimental outcomes. And so what are your thoughts on this? Do you think this is going to be helpful to have a study? We've talked about getting involved, but what do you think the potential impact of this type of legislation is going to happen directly on our law enforcement, on our mental health professionals, on our healthcare professionals? Dr. Broussard, I know you have a particular interest in mental health, so maybe you can start and then Mr. Alexander can weigh in next.
Yeah, I entered this space through, especially with mental health pertaining professionally, as I worked at my fourth year rotation was at the VA working with the veterans. And that's when I realized that I had a problem with mental health, because in our communities, this is something that we don't talk about, right? Family business is family business. What's our business? Stay our business. Even from, a lot of the from our churches, it's a spiritual abnormality. It's not anything that's physiological, but we have to realize that our brain consumes 40% of our nutrients for our body functions, and it's interconnected. So I realized that I had an issue. I'm a person that speaks publicly now about having some fallout, from toxic stress and PTSD as a child. I got 2 DUIs. As a pharmacist, I had to do a lot of work to get to 8 years of sobriety, but I was able to talk about, being a sexually traumatized kid at the ages of 6 to 8, and that's a lot of things we saw with COVID, right? That domestic violence was up, but the reports of childhood abuse was down, and we know that's not the case. It's just that the community are normally the ones that identify it, and by the kids not being in school, you had no one from the outside being able to reach out to the children and get the word out, or get to the proper authorities, or to get the information that a child is being negatively impacted in a very severe way. Children suffer in silence. We don't speak, but I'm here to speak out. And I definitely think that we really need to, you see the bad health outcomes from, this is not even race related, really. The stigmatization of mental health. Schizophrenic people are very more likely to be victimized than to be a threat. A lot of that plays into the social stigmatization of, in particular, schizophrenic people being multi personality disorder, two different things. And public servants, police are ill-equipped to deal with it. I know Richardson has a mental health unit where they go out on non-emergent calls. Grand Prairie, there was an incident I went out to talk to last year. I went out to talk to Tom Hart and Chief Chesney and Steve Dye about a situation. So we started to talk about empathy. I was supposed to advocate for the welfare of humanity and alleviation of human suffering, Black or white. And this particular incident was not a Black kid. And we see it over and over. And it's very unfortunate because we're talking about sick people. We're talking about people that need help, not to be, it's unfortunate.
Thank you so much for sharing your personal story, your personal journey, and then how you've been able to be an advocate. So either Dr. Allen, Mr. Alexander, do you want to weigh in on this one as well?
I would just have to
go ahead, Doc. Go ahead.
I would just have to say, with mental health, it's so true that people don't need to feel like they're being chastised. If they need help, it's okay to ask for help. And as a community, sometimes we don't ask for help. And we've all gone through things. And it's just like, even with COVID, I see it with some of my friends that have experienced COVID, just the impact of it, even with patients, sometimes I've seen it. And so I think this would be a great thing to start, actually, and just to give people a free space and a free zone just to talk and let it out. Because there's a lot of things that we've gone through in our lifetimes, all of us at some point. It could be a death in the family, it could be a breakup or anything that could happen that you still need to have some mental health help with. And I think some of the issues that we're seeing when people go out on, like professionals go out on calls, it would be great to have a team like that set up, just trained to deal with just people that may need an outlet, a safe zone.
Thank you so much for sharing your perspective. Mr. Alexander?
One of the biggest calls that we got from last summer was defund the police, and we had a reflexive response by many state legislatures across the South, banning any type of defunding of police departments, right? And nobody wanted to stop and pay attention to what that actually was going to mean. The police departments in many major cities are taking up over 50% of the city's budget, yet they are not equipped as police officers to deal with a lot of the mental health realities in the city. As you drive around the area, if you go to an underpass, and I work right here at Forest and Central, you see the fencing. The fencing is to police homeless populations from taking over the intersections. Nobody in their right mind chooses to stay out in the elements 24 hours a day. Yet we don't have any coordinated response from the county, from the state, that allows help to be provided to these people. We don't have facilities to allow these people to have a roof over their head and 3 square meals a day. We look at what just happened in Austin, where they banned encampments in Austin, which is essentially criminalizing being poor, because Austin's real estate market is through the roof. And Dallas ain't far behind. So when you're dealing with the fact that people are having to come up with $4,000 a month in some instances just to live in your city, and they don't have a place to start to operate from, how is that impacting us? Dr. Broussard brought up another extremely relevant point, and I'm not going to dovetail too much on what he said. We have a lot of sexual abuse in the community that people don't want to talk about, male or female. And we have a number of victims that exist every day, never having really dealt with their trauma appropriately. They grow into adulthood, they have kids, and they are literally having flashback moments on a daily or weekly basis, and nobody's been there to help them. How is that impacting education? How is that impacting health outcomes when mama is so busy locked up in her room dealing with her stuff, she's not paying attention to what baby girl or baby boy has in terms of their physical ailments, their social ailments, other things that are impacting their mental health as kids. We can't lock up and just wish it away, pray it away. We've actually got to deal with stuff. And we don't have the resources or the network in our community to really effectively deal with the expanse of substantive issues that various members in our community have to deal with. Grandmama can't solve everything. You know, her sweet potato pie might help, but it does not help everything to just sit at granny's house all day during the summer. We've got to have more types of engagement. And one of the things that COVID did was it locked off all of our social connections in really meaningful ways. So how do we find our way back to normal? And what does that start to look like? That's part of what we've got to address and discuss. And I don't think that we shouldn't put on the table, maybe we just have kids in schools for like the next 2 years straight and let them get caught up on where they're supposed to be without any stigma.
Interesting. Interesting perspective. This has been so great. We're going to switch gears and go to the next slide. We have a few more, and I'm trying to be mindful of the time here. And if we can go to the next, perfect. So switching gears just a bit, House Bill 194 would establish a continuing medical education requirement to include hours focused on cultural competence and implicit bias for those who practice medicine, and in particular, general practice, pediatrics, obstetrics, and gynecology. And so, you know, just thinking back about that, what had been your interactions personally with your healthcare professionals? And was there any implicit bias that you experienced in even communicating what you had, et cetera? But what do you think about this? I'll ask you, Dr. Allen, to start with this conversation.
Thank you. I think this is would be great to require some type of education requirements for this, because we're constantly, I know in our profession as pharmacists, doing doing continuing education type things, even to just basic things that are being added onto us. It goes back to what I believe is making healthcare providers be more woke. The more people are educated about racial diversity issues and inclusion issues, the easier these conversations are going to have. And it's funny, people always ask me, April, have you had any healthcare disparities? When I think about my life, and I've had several healthcare issues I've dealt with, I don't recall a true disparity, because I am well educated and knowledgeable in healthcare to understand how to have a conversation about my own healthcare. And even when I did a knee replacement recently, we changed something up on my IV compared to the average patient because of I was able to have that conversation with the anesthesiologist the night before surgery to say, we're not going to do it this way. And he agreed with me on this. But for the average person, they cannot have that conversation. And so that's where some of our disparities come into place, for one thing. But not only do I think this should be for general practitioners, pediatricians, obstetricians, gynecologists, it should be for every healthcare provider. So this bill needs to go back to the House and expand to all healthcare providers. And so that would be the one thing that if I was able to talk to whoever is writing this bill, let's put everybody in it, and let's start talking more about becoming more woke as healthcare providers and being more sensitive as healthcare providers, and not just trying to run people in and out of our offices sometimes, because different things happen to different people for different reasons, for sure. So I think it would be great as a requirement, and it just helps to open the conversation and the door more to get that multidisciplinary group talking about how do we help people better.
I 100% agree with you. Dr. Broussard, any thoughts on this one?
Yeah. Okay. Well, basically, you know, what I see is there has to be, so we have unconscious bias, right? We all do, you know, and it plays out in healthcare. And especially what I see in the medical field, that pertaining to even the interactions between healthcare professionals. I remember when COVID first hit, I'm a part of the Young Black Doctors group on Facebook, and it's like 17,000 physicians, pharmacists. And it was, the hierarchy or the lack of, respect or empathy. So we're constantly fighting, regardless of how educated we are constantly fighting for our dignity and respect. So there were not enough people because they were working so many shifts, trash was building up. Things need to be taken out. And the expectation was, okay, let's ask the Black female doctors to take out the trash and be the janitors. And, these things are totally just disrespectful and unacceptable. And you see that play out just between practitioners. And then you if they don't respect healthcare professionals who are their colleagues, how are they coming into these rooms when they assess the patient? You got the nurse practitioner that does all the typing up, or the PA. They come in for 5 minutes and, they look at you and they look at you as a Black person, and they minimalize, what we have to say. So we're deemed voiceless in our own healthcare. And some of that, what April was saying, we're not as educated because we're healthcare professionals. We know how to fend for ourselves as opposed to the general public. But that should not be on the general public to have to make the best decision and do research and become their own doctor outside of the doctor before they come to the doctor. We have to really raise it's empathy, compassion and empathy, and it starts with humility. We need to really humble ourselves. And how do you teach that? So you have, a lot of doctors that are intelligence quotient, but we're talking about emotional IQ. And that's a third of our total intelligence. And a lot of doctors just do not have it. They haven't been trained. So bringing it to a curriculum or CMEs that can, at least get their mind to thinking, and maybe they can start to evaluate themselves.
Thank you so much. Mr. Alexander, same question.
Where do you start? When you have a disparity in where the treatment takes place, going from a doctor's office on one side of town to other parts of town have to wait for a van to come through to be able to get tested, diagnosed with stage 4 breast cancer. If all you got to do is come to Ledbetter and Lancaster Road and go 2 miles in any direction, and you're at ground zero for stage 4 undiagnosed breast cancer in Dallas County. And that continues south, by the way. When you deal with the fact that most medical practices welcome American Medical Association doctors, but don't really look to bring on National Medical Association doctors. And the recurrent empathy that Dr. Broussard just spoke to, you've got legacy doctors that feel that being a doctor is a rite of passage in their family, but they don't want to come to certain parts of town. They only want to deal with affluence. They want to deal with optional surgeries. They want to deal with things that don't really impact the overall health of the area, the county, the state that they live in. And when that happens, we have a number of communities that are literally suffering because of implicit bias, inherent racism that people are not aware of. They would be the first to say, "Oh, I'm not racist." Then why do you think that this particular patient is better able to handle pain and their pain threshold is higher than any other patient that you're dealing with? They don't need the shot. They've got a built-in ability to handle it better, or there's something about their body. Something about their body makes them in their treatment different from what I would ordinarily prescribe. We have a whole issue over at Charlton Methodist where the entire community is underinsured and people are so afraid to miss money and deal with the fact that they've got an issue that requires attention. They know about it, but they're afraid to deal with it. And by the time they show up to the hospital, doctors are literally saying, all I can do is make you comfortable in your final moments because you've waited too long and death is now inevitable. These are outcomes that are accepted by the state medical community because there's no push to do anything better. And yet we're all acknowledging there's an economic reality that is jobs. There's a social reality that is what part of town do you live in? And then the whole system has its weight on our necks.
This is, oh my goodness. I'm looking at the time. We have two more questions and we'll go quickly. Not that these aren't important because they are, but just because of the time. So maybe just one of you weigh in on this next one. House Bill 136 would establish a working group to establish a registry focused on maternal health. We know that there are detrimental health outcomes for pregnant women, in particular, women of color. And so how do you think this healthcare legislation would have an impact on our community?
I would ask, why do we need it if we have parent parenthood?
Well, let me.
Planned Parenthood went around, so why would you need HB 136? I would ask why.
One of the issues that I know that they're attempting to backdoor is postpartum depression through a study like this. And that's something, there's actually another bill that would allow mothers who delivered 12 months of Medicaid coverage to allow them to get postpartum treatment during that year post-delivery. That doesn't answer everything, but that's one of the things that I know that they want to address.
Absolutely. And so then let's go to this final question, and then we'll wrap up the conversation because I want to make sure we hear from everyone. And that is just, are there any other bills that we should be aware of? You mentioned one, Mr. Alexander, that we should be aware of, or things that you would want to see. And then what advice would you give if people want to get more involved in the communities? I'll start with you, Dr. Broussard, and then Dr. Allen, and Mr. Alexander, and then we'll wrap up.
Okay, well, I'll dive into the second one. It's being more involved. I think it starts with self, working on ourselves and getting our own home, our own mind, our own well-being in order, and once you start to do that, you can start to see how that you have, we always have more in common than what separates us if we start to really look at it. So I look at things in a humanity aspect because we all bleed red, we all suffer from, as a pharmacist, either somebody's sick, either you have a child that's sick, or you're taking care of someone that's sick. And I see that, we really have to understand that we all have families, we all have people that we love, we all have children. And what makes it so different, that the poor people, our poor people in our communities, what makes us so less valued, that we continue to struggle and we see gaps in, life expectancy. In 75216, you're talking about African-American males that are 60, average life expectancy is 63. You go up to 75204, you're talking about 90 years of life. This is, it's appalling, and it's a slow squeeze on Black life. But the thing is, you don't see it happening right before your face. It's not a George Floyd incident that's seen publicly within minutes, how many ever minutes, I didn't even watch it because at some point, you have to protect yourself and have boundaries for this continued, type of, inhumane acts that are against us. And we need to try to protect our children from it the best we can too, because we don't want our children to feel that it's okay to see people that look like you dying in the middle of the streets, because we're not animals. So that's my thing, just to really start to understand that the humanity aspect, and that if you want to get involved, you can always start with, start locally, and try to and grow out. So don't have a great answer for that, but just, just really caring for other people, that's the way I look at it.
That is wonderful. Dr. Allen, any thoughts?
I would suggest people to get involved and volunteer their time, volunteer their talents, volunteer their services in the community. And I know we talked about this last time, it's about taking things to the street, take it to the people, basically. And from a healthcare perspective, we need to start teaching within the professional schools, empathy and diversity and other things to consider for healthcare disparities. And it starts at that first level. From the time that we all enter our P1 year, we should have been being taught about healthcare disparities and going from there. And I think the curriculum in all major pharmacy, medicine, dentistry schools, et cetera, need to look at the curriculum. Then the other thing I would say for people to get involved is to be open. Be open to learn about others, be open into partnering with other organizations and churches and other things. But bottom line, get involved, volunteer, take it to the streets.
Thank you so much. Mr. Alexander, final thoughts?
Two things. First of all, if you haven't joined the NAACP, maybe you should. We talk about stuff like this. We like to bring information like this to our membership all the time. One of the things that I'll point out is the biggest problem that we have is we're in the land of 10,000 bandages for a gunshot wound when the Affordable Care Act did the surgery. We have states that literally don't want to take the big answer that would solve a lot of the foundational problems in society by making public health dollars available to steer activity that goes to teaching nurses and making sure that there's a market for those nurses, that goes to teaching doctors and making sure those doctors have some familiarity in communities of need. And the Affordable Care Act also required that there were studies that dealt with disparate impacts to communities of color, whether they were American Indian, African American, Hispanics, or Asians. And states literally don't want to have that information made available because the shame of the history would be exposed. One of the biggest things that we could do to eliminate a lot of stress is make sure that people have insurance, whether they're Fortune 100 company or they're struggling to get by on part-time money, they have an ability to get insurance. And then we can deal with some other stigmas. But when the biggest obstacle to people walking in the door is, do I have enough money to cover this visit and the prescriptions that may be necessary as a result of this visit, we're still shooting in the dark. We have to do something more substantive, and we have to push this state to have more than 5 counties paying the Medicaid burden for the entire state of Texas. The state legislature has to find money to fund its foundational needs for the state that has grown every year for the last 30 years, and we're still dealing with 1980s budget. So we've got a lot of work to do. We've got a lot of things that need to be addressed. And instead of, dealing with, is this toothpick going to be able to lift my car? We need to do some heavy lifting and bring the tide in to lift all these ships.
And with that, I want to thank our esteemed panel. Thank you so much for your participation. Excellent discussion. We're probably going to have to revisit, bring you guys back. And so with that, thank you so much for allowing me to be the moderator of this session. I'll turn it over to our first Vice President, Ms. Retta Washington McCoy. Thank you so much.
Thank you all. Good afternoon. Good afternoon. Good afternoon. We are at the top of the hour, and I am not going to keep you, but we have to thank our panelists. They have done an amazing job. Again, as we knew they would. This conversation has been great. We've been getting a lot of kudos in the chat and on our Facebook Live. So thank you, Mr. Alexander of the NAACP. And you heard his plug. If you are not involved, that is definitely one organization you want to get involved in. Thank you, Dr. April Allen. You can find her on all social media channels at bloodclots. And thank you, Dr. Richard Broussard. And we have a little QR code that we want you to take a little minute to scan, and you can see how Dr. Broussard is making a difference in our community. We definitely want to thank our participants today, those that may be on our social media channels, as well as those that are in the presentation with us. We cannot do these types of things without you, and we want to let you know that we're going to continue to bring the hard conversations, the heavy content, because we want everyone to get involved. Like Dr. Alice said, we want you to take it to the streets, right? And so with that, we want just to leave you with a few things. All of our social media handles are on this slide. If you have a moment, just take a little snapshot of the slide so that you can refer back to it. But you can find us on Facebook, Instagram, Twitter. This video, as all of our other programs, will be uploaded to our YouTube channel. Like us on all our social media. Find us on LinkedIn. Please scan the QR code, watch Dr. Broussard in action, and we want to leave you with just a couple of call to actions. What are you going to do to help advance advocacy priorities in your community? What ways are you going to get involved and stay informed? You've already been told of one. You can always follow us, and there are plenty of volunteer activities with the National Coalition of 100 Black Women, Dallas Metropolitan Chapter. And then how can you partner with us to bring more awareness to these and other issues that plague our communities? At this time, we are going to say thank you, and we appreciate your attendance today. Continue to follow us on all of our social media channels, and we will be back to you real soon. Thank you.